Thank you very much, Dr. Walid, for this nice introduction. Uh, as we know, there is a very good and very strong rule for the integrated critical care ultrasonography in critical care in general. One of this integrated rule for critical care ultrasonography in general is during the time of weaning from mechanical ventilator. We know that weaning from mechanical ventilation has to be tackled in a very proper way, not to delay the weaning and you buy a lot of complications like VAB and ventilator-induced lung injury, tracheal injury, and many other things. And on the other hand, not to hurry and to extubate somebody who is not yet ready to be weaned from mechanical ventilator. And then the critical care ultrasonography can give you very good guide when to see your patient ready to be weaned from mechanical ventilation. I'm gonna cover two parts of the three very important organs. I'm gonna cover the lung and heart. We know that 25% of time patient they might fail the process of weaning. 25% up to 25% of those who are weaned, they require to be intubated within the beginning 48 hours of mechanical extubation or weaning trials. That's why we have to have readiness criteria for patients to be weaned from mechanical ventilation. You have to be sure that your patient is winnable, ready to start this difficult journey. And then, as per policies, a lot of policies, that you have to go with a sort of spontaneous breathing trial, either pressure support CPAP, or you go with a TPs, and both of them can induce a lot of risk and stresses, both to lung, heart, and diaphragm. Lung, heart, and diaphragm are the common reasons when they fail to induce failure to wean. Walid Al-Habashi will speak about diaphragm tomorrow, and I said, I'm gonna cover heart and lung. 42%, as literature is showing, of failure to wean are coming because of cardiac reasons. And the most injurious or stressful sort of weaning pathway is the spontaneous breathing trial, TPs particularly, when it was compared to the CPAP or pressure support. When you shift from unassisted or assisted to unassisted, there are a lot of changes that might happen. One of them, that you induce a lot of changes to lung and heart, and you can induce weaning, induce pulmonary edema, ischemia, respiratory failure, collapse of the lung, a lot of things. And Xavier will speak about the weaning induced pulmonary edema after the second presentation, the next presentation. But we have to bear in mind that once you shift from a full assisted mechanical ventilation to unassisted mechanical ventilation, you have to be ready that a lot of changes to heart and lung might happen, and this is might consequence left ventricle, particularly systolic and diastolic dysfunction, not only of the left ventricle, but also of the right ventricle, and this might induce failure. We used to say that you have to see the heart before and during and after any stressful or change, major change in your critically ill patients. One of this situation is you have to see the heart and you have to put it in the context of the process of weaning before you start the weaning, during starting the weaning, and after you extubate your patient from mechanical ventilator. Critical care echocardiography can give you a lot of answers to a lot of questions in mind before you attempt to do the weaning and during and after, as I mentioned. If it comes to the systolic function of the left ventricle, shifting from unassisted to or assisted to unassisted mechanical ventilation can induce a decrease in systolic function that can be manifested by decrease in the ejection fraction, more concisely, decrease in the cardiac output, and as Xavier mentioned several times, the surrogate of the cardiac output, which is the VTI, can be reduced by many mechanisms that I'm sure you're gonna hear more during the last presentation of Xavier. Diastolic dysfunction, E to A ratio and E to E prime ratio is very also important when you assess patients before and during spontaneous breathing trial. How can we measure the cardiac output? Or as we mentioned, the surrogate of the cardiac output, which is the VTI. It's very easy. You go to the 5-chamber view, you open the 5th chamber on the apical side, and then you put your cursor in the LVOT just below the aortic valve, 1 centimeter below the aortic valve, and you fire it, you're gonna have the VTI. Very simply, you can measure this. Studies show that low cardiac output / VTI is associated with a high risk to fail. Diastolic dysfunction is also doable in critically ill patients with some restrictions and prerequisites that you have to be aware of. But if the cases are straightforward, that you can do study of diastolic function to see if your left ventricle is relaxing well and can accommodate blood or not, and then it cannot back pressure on the pulmonary circulation and induce pulmonary edema. If the A to A ratio is more than 2 or E to E prime more than 14, they are found to be predictive of failure to wean. Tissue Doppler is very, very important and is easy to do and more yielding than the mitral inflow sometimes to predict if the filling pressure of the left atrium and left ventricle is high and the process of weaning is inducing left ventricle increase in filling pressure and pulmonary edema. This was found to be very, very important when it was compared to other parameters of predicting the success / failure to wean. Look at this very nice study when they compared before they start weaning and after they started weaning, they compared the filling pressure differences. In patients who succeeded to wean, their the E value was significantly less than those who failed to wean. The E prime, which we measure it by the tissue Doppler, at the mitral valve leaflets, medial and lateral, and we take the average on most of the occasions, if this is the E prime is decreased further during or after the spontaneous breathing trial, this is indicated that this patient will fail. And this was found to be very good predictive in predicting the failure to wean. So this also is not less than the RCBI in predicting failure to weaning. And again, it's easy to do in critically ill patients. You do the mitral inflow, see E to A ratio, and tissue Doppler to see the E to E prime, especially if you have reduced ejection fraction. Another study which gives new insight into the left ventricle diastolic dysfunction as a key player in predicting failure to wean. And it was found that the more you have degree of diastolic dysfunction, the more percentage of failure you're gonna have to predict and expect. And you can see here clearly that grade 2 and 3 was associated with almost 80% prediction to fail from weaning from mechanical ventilation. We shouldn't forget that tricuspid, that mitral regurg and aortic regurg plays a role in predicting and suspecting that patients might not tolerate to wean from mechanical ventilation. Why we're saying that? Because some people, they wean their patients blindly without looking at the center of the cardiovascular system, which is the heart. And we have to see if the heart functioning well or doesn't function well. If you have evidence of systolic dysfunction or diastolic dysfunction, there are a lot of interventions that you can do to prepare your patient for weaning from mechanical ventilation. Use nitroglycerin, use boluses of diuresis, use dobutamine to improve the contractility and to decrease the afterload. And this improves the cardiac output, reduces the afterload, will reduce the preload, will reduce the pulmonary edema. Levosimindan, which is not commonly used in our region, but I know it's used commonly or more commonly in Europe, less in the United States, maybe. And this was found by some of the evidence to be a good drug for enhancing the weaning. And you shouldn't forget that you have to pay attention to systolic and diastolic function of your left ventricle before you attempt to wean. I recommend this review, which was very nice and done by a group of good expertise. One of them is Antoine, and they concluded that ejection fraction, if it's less than 40%, among the cardiac output also and the mitral inflow was found when it's lower than the targets you have to have, the likelihood of failure of spontaneous breathing trial will be there. What about the lung? There are a lot of factors that they increase respiratory muscle loads, like when the resistance increases, when the compliance of the lung and chest wall decreases, and when you have intrinsic PEEP, this all will increase the load on the respiratory system, which will increase the work of breathing. What can increase or decrease the lung compliance? Alveolar filling with edema, pulmonary edema or non-cardiogenic pulmonary edema, ARDS, pus in the alveoli, fluid in the alveoli, whatever it is, will decrease the compliance of the lung. Atelectasis, fibrosis, pneumonia, pleural effusion can, and this is underestimated in ICU patients, the chest wall compliance will be decreased significantly by pleural effusion, by increasing intra-abdominal pressure, as well as by obesity. We have to answer this very quick questions before we attempt to wean and during the weaning process, and maybe more important, post-spontaneous breathing. Do I have still wet or dry lung? Do I have still recruited or the lung now is de-recruited? And do we have pleural effusion or not? Wet lung versus dry lung cannot be answered, ladies and gentlemen, by the plain X-ray. Plain X-ray can deceive you. You can see this example of chest X-ray, which looks like normal, no evidence of pulmonary edema. A lung ultrasound, as you see here, is showing you confluent rocket sign or confluent bilateral B lines bilaterally matching with pulmonary edema. On the other hand, if you see this chest X-ray, you wouldn't at all, maybe you wouldn't ask if this is cardiogenic or not. It's a straightforward cardiomegaly with curly B lines and batwing appearance and congestion very frank, and this is cardiogenic pulmonary edema. When you go to the lung ultrasound, you can discover that this is not only cardiogenic pulmonary edema, but there are a lot, as you see here in the bottom left, a lot of consolidation and white areas which are not dynamic, static air bronchogram, which indicates collapse. So the X-ray cannot be relied on. This is the wet lung, and this is here, as you see, the A lines, reverberation of the pleural line, and rocket or B lines here. These signs plus the consolidation sign with an active air, dynamic air bronchogram. You see here bronchogram with a lot of white lines that disappear with inhalation, indicates or pathognomonic of lung consolidations. And this is lung collapse. When you see the lung pulsating in a segment, it means that this segment, plus it's consolidated, plus there is effusion. Why it's pulsating? Because it's collapsed or no air. These signs, ladies and gentlemen, are very important when we come to one of the signs of lung examination that was found to be very important in predicting the failure to wean, which is the lung ultrasound or lung score. We examine patients in 3 zones made by the midline and the sternal line, anterior axillary line, mid axillary line, and posterior axillary line. And then with the nipple line, you can divide them into each zone into 2 areas. an upper and lower area in each zone. So you have six areas in each side. So you have 12 areas in bilaterally. And if you have this finding, you can put a score. When you have a good normal aeration, you see the pleural line and E lines, no B lines, this is 0 point. When you see non-confluent B lines, just 1 or 2, this is 1 point. When you see more than 2 long B lines in one segment or in one intercostal space, you give 2 points. Once you see consolidation, you give the worst, which is the 3 points. And according to this, if you multiply the maximum, which is 3, and minimum, which is 1, to the different areas, you have a score that might start from 0 up to 36. And it was found that when the lung score, which has to be examined and determined bilaterally, if the lung score is less than 13, it's increasing the likelihood of succeed to wean. And the more it goes above 13, the more your likelihood to fail because the lung is de-recruited. And definitively, when you see the lung score significantly high, some people, they suggest number 17, the failure to wean is gonna be very significantly predicted. In this nice trial, they examined 100 patients during their weaning process. 29 of these patients had what they called it post-extubation distress time. And this indicates that this 29 patient weaned, succeeded the spontaneous breathing trial, but they require to have either non-invasive ventilation support, and almost half of them, they require to be reintubated within the 48 hours of the spontaneous breathing. And what nicely was shown by this trial and many other trials, that the lung ultrasound score started before they start weaning a process and patients succeeded to wean was significantly less than those who are in post-extubation distress. They required CPAP or they required to be reintubated. Not only that, but also the lung ultrasound score remained to increase significantly with a very significant p-values at the end of a spontaneous breathing trial for those who failed the trial of spontaneous breathing. And nicely, and this is what we can learn from, is you have to follow your patients whom you succeeded with them with the spontaneous breathing trial, you reach the stage of extubating them. You have to follow and see if this process induced loss of aeration or not. And if you started to see that the lung score increasing stably and upward, you have to have a herald that these patients will fail eventually and might be wise to think of intubating them early. Why is that? Because it was found by many other evidence that delaying intubation carries a lot of morbidity and mortality. To conclude from this study and many others, as I mentioned before, that the lung ultrasound score can be very beneficial to predict the process of weaning if gonna succeed or fail in your patient. And you have to feel comfortable. The lower you have lung ultrasound score, and you have to be very, very annoyed and very cautious if the lung score is above 17, and you have to expect failure to wean. De-recruited lung by lung ultrasound score is found to be very helpful to monitor even post-extubation. Yeah, we all digest the limitations of lung ultrasound. And Dr. Daniel Einstein, who is the father of the lung ultrasound in the world, I think you would agree with me that with lung ultrasound, we don't have panoramic views. You can see only on one spot. And if you have changes which are deep in the lung, you're probably not able to see them, especially if they are surrounded by aerated tissues. And we have also to bear in mind one of the factors that makes critical care ultrasound in general an enemy, and I'm sorry to say that, for some of the senior colleagues in intensive care, at least for best of my knowledge, is the time constraints. You're gonna take the machines and you do the study bilaterally, and this is time consuming. And believe me, if you compare it to the chest X-ray, this is not time consuming at all. And you try this yourself. When it comes to the pleural effusion, which is commonly encountered in critically ill patients, associated with more days on mechanical ventilation and length of stay, associated with, when it's present, collapse and consolidation of the nearby area of the lung. And this is found by many evidence to increase the difficulty to wean your patient from mechanical ventilation. And imagine with me, if you have a patient like this one, with a piece of lung just sinking inside a pool of fluid, would you expect that this lung will tolerate the stresses of being off positive pressure ventilation? Like the other who doesn't have? This study was published on the chest few years back when people compared on mechanically ventilated intensive care patients, those who had a pleural effusion drained with a chest tube versus standard care. What they found, interestingly, that the total duration of mechanical ventilation, as well as the percentage to liberate from mechanical ventilation, was significantly higher on those who had drained their pleural effusion. Why? Because we still listen to questions frequently from the friends in working in ICU asking, why should I drain a pleural effusion of somebody who is not hypoxic, not distressed, while they're ventilated? Believe me, if you relieve the tension on the lung, this would give you a better chance to liberate your patient from mechanical ventilator. Again, this very nice review by Paul Mayo and Antoine Barrault, and among others, is showing significantly and very nicely that the larger you have pleural effusion, the increasing likelihood to have failure to wean. Integrated lung and heart examination is very important and can be very helpful. One of our guest speakers for this conference is Dr. Arif Hussein, the elect president of WinFocus, shared in this nice presentation, though it was a small number of patients, but they examined old age patients who are ready to wean. And they did the lung score and the left ventricle filling pressure, and they compared both. Before they start weaning the spontaneous breathing trial, the global lung ultrasound score was higher on the group who failed to wean from mechanical ventilation compared to those who succeeded before they start weaning. At the same time, there was no difference in the filling pressure of the left ventricle. When they examined the post-extubation patients, they found the same. Those who failed after their trial of spontaneous breathing trial, they had a global lung score significantly bigger, i.e. their lungs were de-recruited after they weaned off positive pressure ventilation. This was obvious again in post-extubation time that there was no significant change in the relaxation evidence of the left ventricle. So you should not rely on one and forget the other, but you have to take both. And evidence is showing that some patients with E to A ratio, which was high, they still have a lung score less than 10, and they were found to be successful to wean. But to what extent, nobody knows. And the bottom line issue that the sensitivity of the lung ultrasound score, yes, it's better than the left ventricle filling pressure, whatever the way you test it, it's more sensitive, more specific as the evidence is showing, but you have to consider both heart and the lung. And tomorrow you hear about the diaphragm. And you have to be assured among
1 minute remaining, Dr. Ashraf. 1 minute remaining, please.
Okay, and you have to be sure to put and include in your weaning pathway. And unfortunately, If you go to the literature and see the weaning protocols, people, they don't recognize, and yet the lung ultrasound and the left ventricle assessment, filling pressure, diastolic dysfunction, and systolic dysfunction. From now on, what we recommend, and this is based on evidence, not only on personal opinion, that you have to take good care of both lung and heart by examining them by critical care ultrasonography before you attempt, during you attempt, and after you wean your patient and extubate, because this was found to be very beneficial, both by literature and by individual management, daily practice that a lot of people they are using. Thank you very much.
Thank you a lot, Dr. Ashraf Al Tayar. Great as usual. You talk about very important aspect, which is the objective parameter for weaning, how to assess the feeling pressure and how to assess lung water score. If the patient has chronic pulmonary fibrosis, do we rely on lung water score for weaning if he has a chronic fibrotic lung chain?
I will answer this partly, and then I leave the microphone for Professor Daniel Einstein to answer more. If you have somebody with chronic lung disease, the issue will be difficult to conclude any study, because to start with, there are a lot of changes due to chronicity of the lung disease, and this might disconfigure the images and disconfigure the finding on lung ultrasound. Daniel, if you just comment on this after you unmute yourself.
Well, thank you. I see the time. I have to leave, unfortunately, for the late speaker. Chronic interstitial disease will always be difficult to win because of the chronicity, but it shows that B-lines is not hemodynamic edema. It's only what I see.
Okay.
I am not clear, but I have not too much time.
Okay.
Regarding what the lung ultrasound score can give, I would read the question because I never did it.
Okay. Hatem
They
Sulaiman,
describe the lesions instead. But I'm sure we see the same things. I describe, they give a number. Why not?
Yeah.
Okay, so thanks very much, and we will head straight away to the next speaker.